So, speaking about CLL, we know that in contrast to a number of the other blood leukemias, or the acute leukemias, which arise from at the level of a blood hematopoietic stem cell in the bone marrow, we know that CLL is a leukemia that arises from at a slightly later stage in the B lymphocytes. We know that CLL is the most common hematological malignancy, accounting for around about 10% of all of the hematological malignancies we see, and accounting for about 30% of all leukemias. When we speak about the incidence, it's around about 5 per 100,000 people per year. But what does that mean in Scotland? In practice, that means that we see around about 180 to 200 new cases of CLL per year. And as the vast majority of patients with CLL will live for many, many, many years, if not decades, with CLL, that means that in terms of prevalence, we have a very high number of people with CLL living in Scotland. It does become more common with age, and the average age of diagnosis is somewhere in the 70s. However, it does affect younger people too, and around about 15% of patients are diagnosed in their 50s. And in fact, this morning I've just consented a patient in their early 30s for a clinical trial. So it does affect younger people as well as being very heterogeneous in the age of people that it affects. It does have a very heterogeneous prognosis, and we do know that some people, the disease, their blood counts just stay very stable, and about a third of people living with CLL will never require any treatment, and around another third will require treatment shortly after diagnosis, and another third may require treatment at some time after a period of watchful waiting. And really one of the jobs we have in the research community and clinical practice is to try and identify and find new prognostic markers that can pick out which patients are going to require early treatment, and then hopefully be able to tailor, when we speak about the newer treatments, to look to pick out prognostic markers that can perhaps influence treatment in future. In terms of how we pick up CLL, as many of you in the room may know, often we pick it up completely incidentally. A number of people might go along to see their GP for a blood pressure check, or and just have some routine bloods done, or go into hospital for an operation and have some routine bloods done, and we find a raised white cell count, a raised lymphocyte count. And when we look at the blood smear, we see fairly normal mature blood cells, lymphocytes with a few smear cells. CLL cells generally look pretty like normal B cells. So what we do to make the diagnosis is send a peripheral blood sample over to our nearest flow cytometry lab, where we look at a number of cell surface markers that give a characteristic pattern that we see in CLL. So we generally make the diagnosis on the peripheral blood sample. So if a patient has attended their GP, had a blood sample done, we can send off the sample and have the diagnosis before we see the patient in clinic. So in terms of clinical symptoms of CLL, often there are none. Often we pick it up incidentally. Some patients may present with enlarged lymph nodes or an enlarged liver or spleen. The CLL cells, as we'll go on to talk about, also circulate through the bone marrow. Normal B lymphocytes sit in the bone marrow predominantly, so we can see accumulation there leading to anemia and infection and bleeding if we see low platelet counts. Infection is a significant problem in CLL, as I'll go into to speak about in the next slide. Sometimes we often see that we know that the CLL cells they affect the normal B and T, the rest of the immune system to quite a significant extent. So they do prevent the normal B cells that remain from producing the normal levels of protective antibodies, which is one of the reasons that we see so frequent infections with CLL. And also, normally the immune system is a very finely balanced machine and there is a part of the immune system that stops our immune system reacting against our own cells, and those cells can be suppressed in CLL as well. So we often see emergence of cells that can produce antibodies that can affect and react against our own tissues, mainly our own red cells, leading to autoimmune hemolysis, or the counterpart where the antibodies stick onto the platelets and lead to ITP. Thankfully, in terms of other things that can happen, thankfully we don't see this very commonly, but sometimes CLL the cells can pick up additional mutations that can lead to it behaving more like a lymphoma, what we call a Richter's transformation, which can be a number of different types of either Hodgkin or non-Hodgkin lymphoma, which we still need which we treat with lymphoma treatment, and we are needing better and more effective treatments to treat that complication. Again, because of the effects on the normal immune system, we can see that patients with CLL can have an increased risk of developing other tumours as well. So in clinical practice, we do need to be very vigilant for that. In terms of speaking about infection, I think I've covered most of this, but in terms of what this means in practice, prevention is what we obviously try to do. So when we treat patients either with fludarabine or some of the newer or other immunosuppressive therapies, we do need to give prophylactic antibiotics, and usually use prevention acyclovir against the cold sore and chickenpox, varicella zoster virus, and also prevention against pneumocystis pneumonia, usually with Septrin or pentamidine. Now, also often for our patients either on treatment or untreated who run into problems with repeated infections, often we do give replacement immunoglobulin infusions, and many of you in this room may be receiving them. We can find that can reduce the incidence of respiratory and other viral infections. That's just given by an intravenous infusion over a couple of hours, once every 4 weeks. For any new patient that we diagnose, we also recommend the annual flu vaccine, and also the streptococcal, the pneumococcal pneumonia vaccine, and the Haemophilus B vaccine as well. So in our first letter that we'll write out to a GP, we do advise that patients receive all of these vaccines to try again to prevent running into problems with repeated infections. We also say in that letter to GPs that patients with CLL should not receive any live vaccines, live attenuated vaccines. So if anyone offers you the shingles vaccine, please politely decline, as you may end up with shingles or chickenpox, which would not be a good thing. So that we always put that out in our first letter. In terms of assessing CLL, I mentioned it's a very heterogeneous disorder. In terms of how we manage CLL, one of the things that we do when we meet a patient or when we follow up patients in clinics is look at staging, and by that we use a fairly straightforward system called the Binet system, where and we do quite a proportion of patients at stage A who will have a slightly raised lymphocyte count in the main, and may have either no palpable nodes to examine, or maybe 1 or 2 small nodes, and are very stable. And for these patients, as many of you will be very much aware, we simply watch and wait. There's at present no evidence that intervening with either standard or newer treatments at this stage for patients with stable stage A disease will affect the natural history of the disease. That may change in future with the newer agents. However, at present, we will simply see patients with stage A CLL a few times a year in clinic to check bloods and examine patients. Looking through in the more advanced stages, stage C, we're always looking for progression to stage C, where we see evidence of bone marrow failure, where the hemoglobin drops down and the platelets start to drop down, and triggers for treatment would be roughly a hemoglobin of around about 100 or platelets of around about 100. But we very much look at trends. We don't look at just one snapshot in time. We want to look at what the bloods are doing, what the nodes are doing over time. And stage B patients are somewhere in the middle. Now, that gives us some indication of how we can stage a patient at one point in time. And in general, as I said, we don't treat stage A patients. Stage B and C patients, stage C patients, we generally do treat. However, there may be some patients who are stage B who are actually fairly stable, who we might still observe for a period of time. And on the other hand, there are some stage A patients who might have a very fast lymphocyte doubling time and where we might actually think of treating if there's clear signs of progression. So what we need are some other markers that can try and give us an idea of how an individual patient's CLL is going to behave over time. So I wanted to say a little bit more in the next few slides about what we know about prognostication in CLL. Before I go on to that, just running over our indications for treatment. It's clear that if we're running into problems with progressive bone marrow failure with anemia, thrombocytopenia, neutropenia and infections, it's clear we need to be doing something about that. Also, if for patients who have clearly large or enlarging or painful lymph nodes or spleen, it's clear we need to intervene. We do look at the rate of the rise of the lymphocyte count as well, and usually a doubling time of under 6 months is an indication that we need to think about doing something. Often for patients who develop autoimmune problems, whether it's hemolysis or ITP, we can sometimes manage that simply with immunosuppression, with steroids or other therapies, without treating the CLL, but sometimes it can be a little more refractory to treatment, and some patients with ITP or red cell hemolysis will not settle until we actually treat the underlying CLL. Now, I've not said anything up until this point about B symptoms, and by that, when you come to clinic, we always ask about whether you've had a fever or any night sweats or been losing weight, which is rare for most patients with CLL, but we can see it, and it's certainly a warning sign when we start to see these things develop. So, going back over to tell you a wee bit more about what we now understand about CLL, to try and understand and try and pick out at presentation, and later on just to try and understand how the CLL will behave and respond to treatment. I wanted to say a little bit more about the underlying biology of CLL. I said at the start that we know that CLL arises in B lymphocytes. So, sorry, this is a bit of a science, but I wanted to say a little bit more about normal B lymphocytes to try and explain a little bit more about what we know goes wrong in CLL cells. So we know that normal B lymphocytes, what they do is they make these specialized proteins, immunoglobulin or antibody proteins, that with each B cell that we have, they will produce a unique immunoglobulin or antibody protein. They will recombine, should be randomly recombine different genes that make up this, that then go on to code for proteins that make up the immunoglobulin or antibody protein, to form a unique protein that has a fairly conserved standard end down here that is then inserted into the cell membrane, and these ends up here as sticky ends that are all unique, that recognise antigens, so normally foreign bacteria or viruses that can come into the body. So And during B cell development, this protein gets inserted into the cell membrane and is tethered, associated to some other proteins here, and then the cell will either sit in the bone marrow or circulate round in the blood, or sit in a lymph node, just patrolling, if you like. And then if a B cell recognises a bug or a virus, if it sticks onto something, what it does, it becomes activated. There's a lot of signals that then switch it on, if you like, and then it goes into a lymph node to then go through a process of proliferation to expand, and then also to make a more effective antibody, to make the most effective antibody it can, and then out the other side of the lymph node, you are produced plasma cells that then secrete the antibody that recognises whatever pathogens coming into the body, and also produces memory cells so that your immune system remembers that you've been exposed to the flu or whatever it is. So why am I telling you about antibodies and immunoglobulin genes? Well, the reason is we've found out that that's very important in CLL biology, as when we looked at large heterogeneous groups of CLL patients and tried to look at different prognostic factors, we looked at, now I should go back to this diagram and just say a little bit more about this process that goes on in here. An activated B cell goes into the lymph node, and then the process of making the more effective antibody involves new mutations, what we call somatic hypermutation, to make a more effective or better fit antibody that then comes out to deal with the infection. So an activated B cell that goes into the lymph node, we see, has just its whichever B cell receptor it was born with, if you like, and then so we would call that unmutated, and out the other side, these have gone through this mutation or better fitting process. Does that make sense? Possibly. Okie doke. I just wanted to spend a bit of time on that, because going on to looking at, we can then look at CLL, look at the B cell receptor, looking at this immunoglobulin protein in patients with CLL, and it was fairly striking. This is now over 15 years ago that it was recognised that patients whose CLL cells have a unmutated, so just a norm B cell receptor, seem to actually progress and do it a lot worse than patients whose cells look like they've gone through that somatic hypermutation process. If you're looking at both just unselected patients or then looking at early stage A patients. So these are patients we'd be watching and waiting in clinic and not really knowing how they're going to behave apart from monitoring the bloods over time. But then when we look at the mutation status, we can see that there's quite a clear difference in progression between patients with an unmutated and mutated B cell receptor. In clinics, some centres can measure, can look at that, but it's quite a technical process. And you may well have heard and read about ZAP70, which is another marker that that is expressed almost exclusively and segregates with an unmutated B cell receptor. So that can be a marker that we can easily look for in clinic to give us a surrogate marker as to the mutational status. So that gives us a little bit better handle. So you could ask me, why the difference? And normally, I mentioned that B cells, once they bind antigen, become activated and signal usually. They will bind, if they stick onto an antigen, they will signal down through the receptor to the nucleus to try and tell them to grow and divide. So we do know that all CLL cells look like they have been activated by antigen, and I'll speak a bit more about that later. But what was recognised now about 10 years ago is that patients with an unmutated B cell receptor retain the ability to signal through the B cell receptor, and that's thought to drive the survival and proliferation of these CLL cells, whereas the CLL cells with a mutated immunoglobulin B cell receptor can bind antigen, but the signals don't seem to go through. So they sit there, they don't die off, but they're not getting the same growth and division signals as the unmutated cases can receive. We do know that, I mentioned that the formation of an antibody protein should be random, but of interest, we know that around about a third of patients with CLL, we can see a very restricted and selected group of antibody molecules, and that the genes that make it up, rather than seeing just a random selection, we see that the same genes are used, which is another indication that CLL cells might bind a particular antigen. There's a lot of work going on to work out what that is, and we do know that a lot of the unmutated CLL cells can bind and bind things that are frequently found on, say, cells, that any of our normal cells that are dying, and so things that they would be able to encounter quite. They might actually recognise parts of our own cells rather than being driven by a virus or a foreign bacteria, if that makes sense. So we now know that CLL is a much more dynamic disease than we used to think. We used to think that CLL arose from B lymphocytes that picked up mutations, and the cells just didn't die off as they should. We now know that the CLL cells actually circulate through the blood into the bone marrow and in and out of the lymph nodes, and we now know that the CLL cells that get into the lymph nodes will encounter and bind and be activated by antigens binding the B cell receptor within the lymph nodes, and that will then drive their proliferation and survival, and that the percentage of cells in the different organs can vary very much from patient to patient, depending on how efficiently they can migrate in and out of the lymph nodes. We also know that within the lymph node, in addition to binding antigen, there are a lot of other cells. I mentioned that CLL suppresses a number of the other immune cells, but it actually stimulates some of the normal immune system, particularly the other type of lymphocytes, T cells, that produce a lot of hormones and cytokines that can promote the survival and proliferation of CLL cells. So this understanding is leading to new targets for treatment by trying to disrupt B cell receptor signaling and the interactions with all of the other survival and supporting cells within the lymph node environment that we think at the moment account for the fact that we can't clear and cure and get rid of all of the CLL cells, as we think that some of the cells, when we give chemotherapy, will be sitting in these very protected environments within the lymph nodes and bone marrow. So this understanding is really offering up a number of new targets for treatment. So we've spoken a little bit about B cell receptor. We know that there's more complexity in addition to that, and this is, first of all, speaking about cytogenetics or genetic abnormalities we can pick up. So these are acquired chromosome abnormalities that we can pick up arising within CLL cells. And at the level of just looking at chromosome preparations, looking for large breaks or losses or duplications of chromosomes, we've known that this is a frequent event within CLL cells really for a number of decades now. And the most common abnormalities, we can see deletion of an area on chromosome 13. When we pick that up on its own, that's actually marks out quite a benign subset of patients who have quite a favourable course and stable disease. However, this is going back to the original publication now, over 15 years ago. the less favourable abnormalities we pick up, we can see deletion of part of chromosome 11 or chromosome 17, where we lose genes that normally trigger cell death or respond to DNA damage, and they can be lost. And this, I want you to remember how this graph looks, because as we go through the talk and I speak about the newer treatments, patients with 17p deletion up until very recently tended not to have very rapidly progressive disease and not respond to standard chemotherapy. However, we are very lucky now that we do have a number of newer treatments that have significantly improved this curve. So thankfully, this is now becoming a historical prognostic curve. So normally in clinical practice, we send, before treatment, we'll send a sample to the lab to look for at least the 11q and 17p deletions by a technique called FISH, where we use fluorescent labelled DNA tags that can go in and bind to particular areas. So we can see that, I think, say, normally with 2 chromosomes we can see 2 little red dots there. I don't know how well that projects. And that's looking at chromosome 13, and you can see the cell's just got 1 copy, so it's got a 13q deletion. So we always do that to look at particularly the 17p deletion before treatment, as that does influence our treatment decision. However, as our understanding of DNA and DNA sequencing has come along, we've identified, and we can now identify much smaller mutations in DNA rather than just looking at losses and breaks of chromosomes. And when we look at using the newer DNA sequencing techniques, we now can identify a number of additional mutations that occur frequently in cells from CLL cells from patients, and we're just starting to understand the significance of these. Now, that really just shows you that there's a whole host of mutations, and the size correlates with the frequency. Some of the newer ones that are coming out, and this is very much still in the research field at the moment and not quite come through to clinical practice, but it will be coming in years to come. We have identified that mutations in a gene called Notch1, which is normally involved in signalling cell growth and differentiation and cell division and cell death, we see that it can be mutated in 10 to 15% of patients with CLL. And when we looked at one of the more recent and key CLL trials, one thing that's come out of that is that patients with a Notch mutation didn't seem to get the benefit of adding rituximab to chemotherapy as patients with, as seen in patients without a Notch1 mutation. So it may be in future that this might possibly influence treatment decisions in future. That is just on analysis of one trial and obviously needs to be borne out in other and larger studies. And we've picked up another couple of mutations that can be seen within patients either at diagnosis or more frequently at relapse, that can indicate that patients will perhaps be refractory to standard chemotherapy with fludarabine or similar treatments. So it may be in future that identifying these mutations can help to tailor appropriate therapy. We now know that CLL is not, I've mentioned that, I've hopefully made it clear that we know that within different patients may have different mutations that can lead to CLL, and CLL is not one disease, but what we understand now as well is that even within one patient with CLL, all of the cells are not exactly the same, and that often over time, perhaps at diagnosis, there's the cell that leads to CLL, and then perhaps going through treatment, there may be, there can be different cells within the total CLL population that have picked up different mutations. And what we know can happen is that with treatment, say with fludarabine treatment, we do know that if there are some cells that perhaps have a 17p mutation, that when patients relapse, we can see that those cells survive and then can expand over time. And we know that, say, picking up a 17p deletion is more common at relapse compared to presentation. Also, we know over time we can see new mutations that just develop within the clone and may expand. So we do know that what we're wanting to do is clearly design better treatments that can clear as many of the cells, and using combinations that can perhaps kill off different populations that have different mutations, to ideally cure and prevent relapse. So going on, just I'll say a little bit about, this is really the past bit of my talk too. I'll say a little bit about our historical development of treatment of CLL and speak about how we arrived at our current standard of care. Really going back about 50, 60 years, we unfortunately had very few treatments for CLL, and those treatments we had were largely palliative. Either we used quite high dose steroids, which we still use today for some indications, or used generally oral chemotherapy drugs, chlorambucil, which falls under the heading of an alkylating agent drug, which does affect DNA replication. These were taken orally and were effective in the short term. However, most patients would only have benefit for around about 12 to 18 months before the disease came back again. So it's clear we needed more effective treatments. Then now, going back around about 30 years ago, we saw the introduction of purine analog drugs, which the most widely used is fludarabine, and we found them to be markedly more effective than the alkylating agents, such as chlorambucil, when used alone. That then led to a trial looking at whether the combination of the two types of chemotherapy drugs acting in different ways may be yet more effective, and we did see that to be the case. Following on from that, our current standard of care leading to chemoimmunotherapy, now around about 10-15 years ago, we started looking at monoclonal antibody therapy. Now, you'll be experts in antibodies now. I've spent a good bit of time talking about them. So you will recognise this structure at the top. So rituximab is a therapeutic agent, a drug that's been synthesized in the lab to have the same structure as a normal antibody, but the end that up at the top that normally recognises foreign pathogens has been designed to recognise something called CD20, which is a protein that sits on the surface of B lymphocytes on the CLL cells and their normal counterparts. And it's given intravenously and then will bind onto the surface of the cell, so works at the cell surface rather than the chemotherapy drugs that go in and work at the level of the cell nucleus. And what rituximab does is then activate elements of the normal immune system to then attack and kill the CLL cells. When it was used initially as a single agent, we didn't see too many responses, probably because CLL cells don't have too much of the CD20 on their surface. And patients with high lymphocyte counts, there's a lot for it to bind to when we use standard doses that we use in other lymphomas. However, when it is used in a higher dose, which we now use and used in combination with chemotherapy, there's a large trial looking at that called the CLL-8 trial, a German trial, where a large number of patients were randomised. It was a phase 3 randomised trial where over 800 patients were randomised either to receive 6 cycles of fludarabine and cyclophosphamide alone, or with rituximab for 6 courses, and followed up. And it was fairly clear when we looked at the length of remission, and the first graph is looking at progression-free survival, so length of remission, and the green line is the group of patients receiving FCR, with rituximab clearly are doing better than patients who just received chemotherapy alone. So that really, this trial led to FCR and rituximab being licensed and approved. That's a good number of years ago now for use in clinical practice. So, and also looking at low levels of minimal residual disease, which we can look at in the blood or bone marrow following treatment this is data from the same trial looking at different time points and looking in the blood or bone marrow. And really what it's showing, I'm sorry, the figures are small there, it's showing that at all time points and whether looking at the blood or the bone marrow, adding rituximab significantly increases the number of patients who have a remission that's of the level that we can't pick up any detectable low-level residual disease by the techniques used. So that really led to it becoming the standard of care. So you could ask me, why do we need new treatments? Do I need to do another talk? Well, as many of you may know, going through FCR, and when we sit down and speak to anybody needing treatment with FCR, we do need to speak about side effects. Within the CLL-8 trial, we know that the average age of patients in the trial was only in the early 60s, and we do know that doesn't reflect the patients we see in clinical practice. And even within this trial, looking at younger, generally fitter patients, then we know that around about a quarter of patients didn't manage to complete the 6 cycles of treatment, either due to effects on the normal bone marrow stem cells and prolonged cytopenias, low blood counts, and also we know fludarabine is very immunosuppressive, and a number of patients ran into problems with infection. So we really need more effective treatments with fewer side effects. Currently in the UK and US, generally we do not use FCR in patients over 70. However, that's obviously a line in the sand, and we do take everyone as an individual, and there's a little bit of wiggle room there. Also, one of the problems with FCR, we do know unfortunately that patients that harbour the 17p deletion show very poor responses to FCR, and generally in patients in the early trials who received FCR, most tended to relapse within around a year. So we clearly need more effective treatments for this group of patients. More on that later. And we do also know that fludarabine can trigger an autoimmune hemolysis, which can be very severe and can actually be fatal. So for patients who present and have refractory and difficult to treat autoimmune hemolysis, we can't give fludarabine we need to be looking at other therapies. And as I said, fludarabine, whilst being very, very effective CLL treatment, we know that, and it remains that. We do know that around about 1 in 5 patients do develop prolonged low counts after treatment with fludarabine, and can actually pick up stem cell mutations in their normal stem cells, leading to myelodysplasia, so leading to another bone marrow condition in itself. So we've spoken up until this point about our development of treatment up until around about this point. I'm not going to say too much about transplant at the moment. And I've spoken about the limitations of treatment. Luckily, over the last few years, we have had really an explosion of additional treatments working in different ways, from new antibodies to new drugs that work on targeting more particular survival pathways in B-cell receptor signaling and other pathways that I'll speak about in the next talk. But